Welcome to the Creative Commons RX podcast. Before diving into this episode, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.
Biologic therapies are incredible, right? They're these revolutionary medicines that are tackling some of the most complex diseases out there. But they have this hidden vulnerability, a secret weakness that comes from the last place you'd expect, our very own immune system. So let's just jump right into the big question here. What happens when the exact system that's designed to protect you decides that your life-changing medication is actually a threat? That's the fundamental conflict we're going to unpack today. Okay, so there's a technical term for this whole phenomenon, immunogenicity. But really, all it means is the tendency for these protein-based drugs to tick off your immune system and provoke an attack. And the most immediate result? Your body starts getting rid of the drug way too fast, which of course means it's not going to work as well. So let's get into the nitty-gritty of this internal civil war. How, and more importantly, why does our body's super sophisticated defense network get it so wrong sometimes? Well, the immune system's weapons in this fight are called anti-drug antibodies, or ADAs for short. And you can basically think of them in two flavors. First, you've got the quantity killers. These guys just form clumps with the drug, tagging it for quick removal. They lower the amount of medicine in your system. But then, you've got the quality killers. These are way more sinister. They directly sabotage the drug, blocking the part that does the actual work and making it pretty much useless. So where do these antibodies come from? It's really a four-step case of mistaken identity. First, your immune cells kind of eat the biologic drug. Then they chop it up and display the little pieces on their surface. Step 3, your T cells, which are like the security guards of your body, see these fragments, don't recognize them, and they sound the alarm. And that's the final step. The T cells give the green light to your B cells to start churning out those anti-drug antibodies. Okay, so if that's how it happens, what makes it more or less likely to happen in the first place? Well, it turns out the risk is this complicated puzzle. It involves the drug itself, your own unique biology, and even how the treatment is given. Let's start looking for some clues. Now, this table tells a pretty amazing story of scientific progress. We started with antibodies that were 100% from mice, murine. And as you can imagine, our immune systems freaked out. So scientists got smarter. They engineered them to be more and more human, going from chimeric to humanized and finally to fully human. And you'd think, problem solved, right? But here's the fascinating part. Even fully human antibodies can still trigger a response. Why? Well, because the very parts that we engineer to make them work better can sometimes create new shapes that our bodies have just never seen before. And the risk goes way beyond just the protein sequence. If the drug molecules start to clump together, that's like a giant, flashing danger sign to the immune system. Same goes for really tiny details, like the pattern of sugar molecules that are attached to the protein. Heck, even microscopic impurities left over from the manufacturing process can act like hype men for the immune system, amplifying the whole attack. Now, let's shift to the patient side of things. And this is where it gets really personal. I'm talking about our genes. Scientists have actually found a specific gene, HLA-DQA1-05, that's a major risk factor for developing antibodies to some of the biggest drugs out there. This is a massive clue. It points to a future where we could screen patients for this genetic risk before they even get their first dose. And of course, other things unique to you matter too. Your age plays a role, since your immune system changes as you get older. The disease itself is a big factor. If you have an autoimmune condition, your immune system is already on high alert. And your immune system has a memory. If you've taken a similar drug before, it might be primed and ready to react. It all just goes to show how much your personal history is part of the equation. And finally, how the treatment is given can make a huge difference.
It's kind of funny. It's all about finding this Goldilocks zone. Counterintuitively, higher, more consistent doses can actually teach the body to tolerate a drug. But taking drug holidays or breaks can increase the risk. We can even use other immunosuppressant drugs alongside the biologic to proactively tell the immune system to calm down. The whole goal is to keep that drug concentration just right. So, we know what immunogenicity is, and we have some clues as to what causes it. But how do we actually find these rogue antibodies when we think there's a problem? Let's open up the clinical detective kit. Well, regulators recommend this really logical 4-tiered approach. Think of it like a funnel. First, you screen. You cast a really wide, sensitive net to catch any potential positive. Next, you confirm, using a much more specific test to get rid of any false alarms. Third, you titrate, which basically just measures how big the immune response is. And finally, the most critical step, you run a test to see if you're dealing with those nasty quality killer antibodies. But really, the cornerstone of all this surveillance work is something called therapeutic drug monitoring, or TDM. And this is so important. It's not just about reacting when there's a problem. Proactively monitoring drug levels is one of the best tools we have to prevent immunogenicity from ever getting started. It helps us stay in that tolerogenic window, that Goldilocks sweet spot. But what about the most extreme situations? I mean, what if a patient has a severe allergic reaction to a drug that they absolutely cannot live without? For these really high-stakes cases, there's a remarkable procedure called rapid drug desensitization. And the protocol is incredibly precise. You can see here it involves preparing multiple IV bags with weaker and weaker dilutions of the drug. Then it's given in about 12 tiny incremental steps, slowly ramping up the dose. What this does is it safely coaxes the immune system to stand down, creating a temporary truce, basically, so the patient can get their full dose. But because it's temporary, they have to do this every single time. Okay, so let's put all the pieces together. When a patient's treatment just stops working, we don't have to guess why anymore. We have a data-driven playbook, an algorithm to tell us exactly what to do next. And this algorithm is so powerful because it gives us a clear path. You measure both the drug levels and the antibody levels, and that leads you to one of 3 situations. Scenario 1. Drug levels are fine, but the patient's not getting better. The problem isn't immunogenicity. The drug's mechanism probably just isn't working for them anymore. Time for a new class of drug. Scenario 2. Drug levels are low, but antibodies are also low. You can probably just increase the dose. But scenario 3, that's the classic signature of immunogenicity. Low drug, high antibodies. And in that case, the best move is to switch to a different biologic drug. So, with all of this complexity, who's the expert guide through it all? Who's connecting the dots between the product, the patient, the tests, and the treatment plan? Well, that's where the clinical pharmacist comes in. They are absolutely pivotal in this whole process. Right from the very beginning, they're assessing a patient's risk, they're pushing for strategies to prevent antibodies from forming in the first place, they guide the testing, and, crucially, they help interpret all of this complex data and apply that treatment algorithm to figure out the right way forward. They are the ones connecting all the dots and making sure patients stay safe. So, what's the big takeaway here? Managing immunogenicity is, without a doubt, a complex challenge, but it is absolutely a solvable one. With the right knowledge, with proactive surveillance, and a really smart data-driven strategy, we can manage this problem and keep these amazing therapies working. And that kind of leaves us with a final big picture thought. As we dive deeper and deeper into this era of personalized medicine, where treatments are tailored to our individual biology, could a deep predictive understanding of our own unique immune response be the next great frontier?
This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.